Dear Christian, thank you very much for the nice introduction. Dear Professor Mills, dear friends and colleagues, thank you very much for the opportunity to be a part of this fantastic meeting and to talk today about the direct comparison of high sensitivity cardiac troponin T and I in the early diagnosis of myocardial infarction. I'm very honored to be a part of this senior scientist's lecture, and I was quite amused by the official invitation from the committee pointing out that senior scientists, as a rule of thumb, in contrast to masters, do not yet have gray hair or still have hair. But I think, of course, the committee is still right, since even if I'm not a statistician, I think there's a clear correlation between the age index and the amount of hair. When I look at myself, honestly, I do not even know if I have an age index, but my hair is getting lighter and lighter from year to year. But when I look at my more experienced colleagues and previous speakers, but also role models, they have, of course, a much higher age index, but also the amount of hair is getting a little bit lower. And I think in this room we all would agree that we know at least one absolute expert with an almost unmeasurable age index, but also an almost unmeasurable amount of hair. But as always, there's an exception, and I call it the Mills paradox, and I'm very eager to meet Nick later this evening to talk about secrets how to get a high age index but still keep the hair. I don't know if troponin is the solution, but I'm very happy to talk about it today, and these are my disclosures. But my most important disclosure slides are this one here. I'm very thankful for the support of the Cardiovascular Research Institute in Basel to open the doors also for a surgical resident, and for the great network for the support. So the clinical introduction of high-sensitivity cardiac troponin assays represent a major achievement not only in the early diagnosis of myocardial infarction. The current guidelines for the early diagnosis of acute MI recommend the routine measurement of one of the cardiac-specific isoforms, either cardiac troponin T or troponin I. Further, they assume that both cardiac troponin T and I concentrations reflect identical pathophysiological processes and are therefore equally effective in the detection of myocardial injury and therefore myocardial infarction. However, we also do know that differences between cardiac troponin T and I have been reported, especially regarding diurnal rhythm, prediction of all-cause or cardiovascular mortality, and, for example, release dynamics. So it seems a little bit that cardiac troponin T and I are same, but still different. So we aimed within this project to directly compare cardiac troponin T and I in the diagnostic performance for the early diagnosis of acute MI, with a special eye to the relevant subgroups of female patients, early presenters, patients with renal dysfunction, known coronary artery disease, and elderly, but also regarding the prognostic accuracy for all-cause and cardiovascular death and myocardial infarction in the future. Furthermore, to evaluate some potential clinical consequences, we aimed to directly compare troponin T and I when embedded as recommended by the ESC in the respective assay-specific algorithms. To address these questions, we used data from our international multi-center PACE trial, where we included patients presenting to the emergency department with chest discomfort. The final diagnoses were adjudicated by 2 independent cardiologists, and I want to spend a little bit of time to further highlight the adjudication process for this trial. The final diagnoses leading to the ED presentations were adjudicated according to current guidelines and the 4th universal definition of myocardial infarction using 2 sets of data. First, all available medical records obtained during clinical care up to a 90-day follow-up, so including clinical history, physical examination, results of laboratory testing and radiological findings. And second, study-specific assessments, including detailed chest pain characteristic and serial measurements of high-sensitivity cardiac troponin concentrations obtained from study blood samples. For this project, we really performed 2 totally independent adjudications. First, using as part of the study-specific assessment serial measurements of high-sensitivity cardiac troponin T concentrations, and second, using high-sensitivity cardiac troponin I architect blood concentrations. We will always report the findings for both adjudications. We call it using troponin T or troponin I for the adjudication. So this is our study cohort. We included more than 7,600 patients in this trial, of which about 1,400 patients had an adjudicated myocardial infarction. It's a typical chest pain cohort with a median age of 60 years. About 34% of the patients were female, and the same amount of patients were early presenters, meaning presenting within 3 hours after chest pain onset. Now here you can see the distribution of the final diagnosis when using troponin T for the adjudication process. And when we compare these diagnoses to the diagnosis when we use troponin I measurements as part of the adjudication process, we see some minor differences regarding the amount of patients with adjudicated myocardial infarction, which was slightly lower in patients when using troponin I for adjudication, and regarding patients with unstable angina, where the amount was a little bit higher when using troponin I for the adjudication process. Now, what about the diagnostic accuracy of high-sensitivity cardiac troponin T and I at presentation for non-ST elevation myocardial infarction? And here you can see that high-sensitivity cardiac troponin T had a very high diagnostic accuracy, regardless if we use troponin T or I as part of the adjudication process. High-sensitivity cardiac troponin I also had a very high diagnostic accuracy, which was even statistically superior when using troponin I for the adjudication process, whereas we did not see a statistically relevant difference when using troponin T for the adjudication process. Similar findings were seen in the relevant subgroups of early presenters. Again, very high diagnostic accuracy of troponin T and I, again, significantly superior for troponin I compared to troponin T when using serial measurements of troponin I for the adjudication, whereas no difference was seen when using troponin T for the adjudication process. And these findings were consistent in all relevant subgroups: female patients, patients with renal insufficiency, patients with coronary artery disease, or elderly patients. Always a benefit for troponin I compared to troponin T when using troponin I for the adjudication process. Now, how about the prediction of all-cause death? And here you can see the area under the curve and the respective difference in the area under the curve for prediction of all-cause mortality. And what we can see here is that high-sensitivity cardiac troponin T was superior compared to troponin I after around day 75 for the prediction of all-cause mortality. And similar findings were seen for the prediction of cardiovascular mortality. Also here, a little bit later, troponin T was superior compared to troponin I after around day 90. For the prediction of future myocardial infarction, there was no difference seen for troponin T and I regarding myocardial infarction within 730 days. Now, have these findings clinical consequences? And therefore, we analyzed and directly compared the two algorithms, the assay-specific algorithms on the left side for troponin T Alexis and on the right side troponin I Architect with the assay-specific cutoffs. And what we can see here is that both assays performed excellent, with a very high safety for rule-out with a high negative predictive value and a high sensitivity, and with a very high accuracy for rule-in, indicated by a high positive predictive value and a high specificity. Also, the efficacy of both algorithms was very high, with only a small amount of patients remaining in the so-called observe zone. Only 1/4 of the patients could not be triaged into rule-in or rule-out within 1 hour. What are the limitations of this project? Even if we used a rigorous methodology, with always a chance of a misclassification in a small number of patients, we cannot generalize our findings to patients with terminal kidney failure requiring dialysis, since these patients were excluded. No specific sample size calculation was performed, and therefore, even if it's one of the largest diagnostic trials ever performed on this topic, it may have been underpowered for some comparisons. And further studies evaluating other high-sensitivity cardiac troponin I assays are warranted, since we used in this study the most validated troponin I assay Architect, which is on the market. So we want to conclude that there seem to be differences between cardiac troponin T and I regarding the diagnostic accuracy for myocardial infarction. This was consistent in all relevant subgroups. Troponin I was superior to troponin T when using an adjudication based in part on serial measurements of high-sensitivity cardiac troponin I. However, the prognostic accuracy was significantly higher for troponin T regarding all-cause mortality and cardiovascular mortality. Now, the clinical consequences of these findings need to be further evaluated, since both assays performed excellent when using in the respective assay-specific algorithm as it is recommended by the ESC. And with this slide, I want to conclude, and thank you very much for your attention.
Okay, I think Andrew was first. Likely he has the same comment as I on your selection of the pictures that you show.
Thank you very much, Luca, for the advance notice of your first figure today. It was very polite of you. And a question really regarding the methodology and the implications of your outcome data. So comparing INT is obviously very challenging to do in a robust manner. One of the issues is different hospitals will have used different assays in clinical practice on which to guide investigation and treatment. Were you able to do a sensitivity analysis where you looked at the particular assay in use at that site and whether that had any implication for whether the I or the T assay was more prognostic?
Excellent aspect. Thank you very much, Andrew, for this comment. No, we haven't so far performed the sensitivity analysis regarding this. I think one of the main strengths of this project and of this adjudication process is that we really used samples, study-specific samples, where we really had the both assays comparing. But you're right, also the clinical tests performed at the respective clinic was part of the adjudication, and we further could do the sensitivity analysis. Absolutely.
Salvatore, please.
Okay, Luca, first of all, we have a special meal for you tonight as a captain, so take care and so that you'll be perfect tomorrow to play. No, Saturday, so we have a special meal for you. Then the question is, it seems that now you have to perform a both. I'm joking, right? One in terms of adjudication, one in terms of prognosis. But I think the question would be a little bit more complex to see which is the reason that physiopathologically you think this is the question, that are implying these two different results. Do you have any explanation for that?
Yeah, thank you very much, and I think this is the big question for all of us. I think this project also opens some doors back to basic science, where we really have to find the differences, release mechanisms, reuptake mechanisms of both troponins. We have some data, and this is work in progress, of course, at the moment, that we see that troponin T seems to be a stronger signal for chronic myocardial injury, whereas troponin I can be a signal for more acute pathologies, and therefore this could be a part of the explanation why, for example, for prognosis, troponin T may be superior, while troponin I is perhaps beneficial for the diagnosis of an acute pathology. But of course, this is work in progress, and I think there are several aspects leading to these results and findings.
Just while we're getting the microphone there, can I ask? I think that's a really important point you've just raised, and I was thinking as I was reviewing your data there that may well be the explanation. It would be nice to report, in addition to the PACE diagnostic classifications of MI, unstable angina, non-cardiac chest pain, to also report the distribution of the universal definition of myocardial infarction criteria for the two assays, if you've adjudicated both, because I think you might well be right that chronic myocardial injury with troponin T is possibly having an impact on diagnostic performance, but yet identifying a very important group of patients that have poor outcomes. So if you have the ability to look at that, it would be really interesting.
As always, excellent comment, and thank you very much.
Do you have data about the proportion of use worldwide of troponin I or troponin T? Do you have data?
So I personally do not have this exact information, but of course here in the room plenty of persons know how the worldwide distribution of troponin T and I is. I personally do not know it. We in Basel, we use troponin T for the clinical course, but for the study examples we had both.
In terms of cost, of price, is a big difference between one and the other?
It probably depends on the country, the negotiations, I don't know.
Other questions? Yes, one more question for Luca.
Thank you so much. It was really interesting study. And 2019 circulation, there was a paper like a troponin I is more specific for cardiac or composite cardiac mortality, but troponin T is much more non-cardiac mortality or non-cardiac cause. Is this your idea about your study? What do you think?
Yes, excellent. And of course, we discussed these findings also. I mean, it's findings from the group, from Nick Mills and the group. when I have it correctly in mind, there was also the endpoint for acute myocardial infarction and other cardiovascular events. And this can be complementary to our possible explanation that troponin I is perhaps beneficial when it's about diagnosing acute pathologies, for example, as acute myocardial infarction. However, for the prognosis of survival, troponin T may be beneficial due to the more chronic, or to the association with chronic myocardial injury, and due to a possible stronger association with age in general.
So perhaps one last question. I mean, the difference is tiny, tiny, tiny. It's significant because it's a huge data set. So we do not know whether it has clinical implication, but can you speculate, because it was only one assay that was compared, and that other assay has a higher analytical sensitivity as compared to the T assay that was used. Could the small difference be all due to the analytical advantage that this assay has compared to the other? What would you speculate?
I would suggest to do further validation studies using other troponin assays to see if this really is a potential explanation. I think, as I said, we really have to be careful when interpreting these findings, since if there is a clinical consequence, yes or no, this is one topic. The other topics are the reasons. I think there are pathophysiological reasons for it, but there also may be analytical reasons, and therefore we need to have further validation studies using other high-sensitivity cardiac troponin I assays.
Okay. Thank you, Luca.